Cast is now starting. All attendees are in listen-only mode.
Right. Good day, everyone, and welcome to today's partner webinar, Swing Bed Review and FAQ. Our speaker today is Carolyn St. Charles, Chief Clinical Officer for HealthTech. At this time, all lines are on mute to prevent background noise. We will have a Q&A period at the end of the presentation. Type your question using the question pane to the right of your screen. They will be answered in the order they were received. Please identify your organization at the beginning of your entry. A copy of today's materials can be downloaded as a handout from the sidebar during this webinar in PDF format. Also available in the handout section is info regarding CIHQ accreditation, the 24 Jubilee Summit, and HealthTech services. To view the handout section, click on the small orange arrow at the top of your screen to expand the menu. This webinar is being recorded and will be available via a new YouTube link within a couple of business days. Mark your calendars for the second Tuesday of each month, noon Central, for future partner webinar offerings. It's now my pleasure to turn the conference over to our speaker, Carolyn St. Charles. Carolyn, you have the floor.
Michelle, thank you so very much. And thank you for letting me be your first partner webinar. So I appreciate that very much. So let's get started. So as Michelle said, my name is Carolyn St. Charles, and I am the Chief Clinical Officer for HealthTech. So here's what we're going to talk about today. First, a bit of an introduction. We'll talk about regulatory sources, criteria for skilled care, pre-admission, admission, continued stay, and discharge. So basically from pre-admission to discharge, all about swing bed. So this is our standard disclaimer, and basically what it says is that you should always check regulatory sources, whether the information is from me or from other speakers or consultants. Always check the regulatory sources. All right, so let's start with a little bit of a background and talk about what is swing bed. So the swing bed program actually was part of a reimbursement mechanism. It was part of the 1980, oh my gosh, that's a long time ago, budget reconciliation project. And that allowed certain small rural hospitals to basically have a swing bed program. Now, in accordance with that, now we're talking about 1997. So non-CAW swing bed facilities are covered under the SNF prospective payment system. So basically, if you are a PPS hospital and you have a swing bed, you're paid basically under the same methodology as a skilled nursing facility. So you have to submit an MDS, minimum data set, and then you are paid according to that system. If, however, you are a critical access hospital with swing bed, you're exempt from the SNF PPS payment methodology and are paid 101% of reasonable costs. Those reasonable costs are determined every year as a result of your cost report submission. So you're paid a daily rate, just like the inpatients, your Medicare inpatients, but also for swing bed. So PPS, you're paid prospective payment. CAWS, you're paid based on 101% of reasonable cost. So a couple of FAQs, and I've put some FAQs throughout this presentation. So you're not required to have a separate unit or designated bed. So for example, if you have a 20-bed unit or a 25-bed unit, you can intersperse swing beds throughout your acute care beds. So they do not have to be in a designated area. In addition to that, for critical access hospitals, as you know, CMS requires you to have a 96-hour average length of stay annually for all inpatients, but your swing bed days are not included in that 96-hour average. So let's talk a little bit about regulatory sources. So where can you find the regulatory sources related to swing bed? So first of all, CIHQ does have accreditation standards for critical access hospitals that include swing beds. Joint Commission, D&V also have standards for swing beds embedded in their standards. Conditions of participation for critical access hospitals, conditions of participation for hospitals, so Appendix W and Appendix A, and then conditions of participation for long-term care facilities, Appendix PP. So Appendix W, Appendix A, both have critical swing bed regulatory requirements, but neither of them have interpretive guidelines. So to find interpretive guidelines, unfortunately, you have to go to Appendix PP. And then I've provided you with 3 other regulatory sources. So Medicare Benefits Policy Manual Chapter 3, Claims Processing Chapter 6, and the Benefit Manual Chapter 8. So all 3 of those have information about billing, reimbursement, criteria for swing bed. Of those, I would say Chapter 8 is probably the most important because that includes the criteria for swing bed. So these are the swing bed standards in CIHQ, and I've listed them here. So there are a total of 16. These are the regulations in Appendix W. As you can see, there are 12 tags, but it's also important to know that other regulations throughout Appendix W would also apply. And then Appendix A, 11 tags, and again, other standards, says Appendix W, sorry, should have said Appendix A. So other standards also apply as well. So for example, medication management, those type of standards, they're going to apply to your swing beds as well. So as I said, there are no interpretive guidelines in Appendix A or Appendix W for swing bed, and you're required to go to Appendix PP. So what you'll find is just a comment that says refer to Appendix PP for interpretive guidelines and refer to Appendix PP for survey procedures. Now, when you go to Appendix PP and try to find interpretive guidelines, it's not always very easy, but this is just an example related to food and nutrition services. So there is intent and guidance, which you can utilize as the interpretive guidelines if you're wanting to look at what does that standard in Appendix W or Appendix A really mean. So Appendix PP has a total of 22 tags, which are listed here. So in your appendix, and I'm not going to go over it today, but in the appendix, you have a crosswalk that really looks at the standards in Appendix W and where you can find interpretive guidelines in Appendix PP. I would also add that CMS has indicated that they have no intention of ever adding interpretive guidelines to Appendix W or Appendix AA or Appendix A. CMS seems to think that we are all perfectly capable of using Appendix PP. All right, so next topic. Let's talk a little bit about Medicare swing bed criteria. So what criteria does a Medicare patient have to meet in order to be admitted to a swing bed? Now, let me just say that this is for Medicare. So other payers, Medicare Advantage plans, for example, have their own rules, and they do not have to follow the requirements for traditional Medicare. All right. So as I mentioned before, this is Medicare Benefits Manual, Chapter 8, and this has a lot of information about criteria and what types of patients qualify for swing bed. So here's some basics. So in order to be admitted to swing bed, a Medicare patient has to have 4 factors, and they must all be met. So first, the patient requires skilled nursing or skilled rehab. The patient requires those skilled services on a daily basis. As a practical matter, the daily services can be provided only on an inpatient basis, and the services are reasonable and necessary for the treatment of the illness. So CMS says if any one of those 4 factors are not met, that a stay in a SNF or swing bed, even though it might include the delivery of some skilled services, is not covered. Another criteria is a 3-day qualifying stay. So to be admitted to a swing bed, a Medicare patient must have 3 consecutive calendar days, totaling 3 consecutive days. But the regs say that that can be in 1 or more hospitals. So you could have a patient, for example, who was admitted to a critical access hospital for a day, transferred to an acute care hospital for 2 more days, then that would meet the 3 calendar day requirement because it was consecutive. Time in observation does not count. Time in the emergency room does not count. So I know that for many facilities, particularly looking at your observation stays and admitting patients to observation for the first 48 hours, that can significantly impact whether or not a patient qualifies for swing bed. Now, I suppose the caveat that I should add, obviously, if a patient is appropriate for observation, they need to be admitted for observation. I'm just trying to make the point that observation does not count towards that 3-day qualifying stay. All right, so the treatment of the condition received during the hospital or the SNF stay is another criteria for admission to swing bed. So this can include either the reason that a patient was admitted to an acute care hospital, let's say a fractured hip, or something that occurred during that hospitalization, pneumonia. So either of those could potentially qualify the patient for a swing bed stay. Principles for determining if a service is skilled is one of those things that is very, very important. So obviously, if a patient doesn't meet criteria for skilled care, then they can't be admitted. So Medicare says that if the inherent complexity of the service is such that it can be performed safely and or effectively only under the general supervision of skilled nursing or skilled rehab, then it is a skilled service. However, Medicare also says that the patient's diagnosis or prognosis should not be the sole factor in deciding that a service is not skilled. So yes, it should be taken into consideration, but not the sole factor. So Medicare also requires daily skilled care. However, that is defined as 7 days a week for nursing, but only 5 days a week for rehab. Now, a bit of a caveat here. Even though Medicare says that rehab is only required 5 days a week, it must be provided at the frequency required by the patient. So if a patient requires therapy 7 days a week, then you must provide that 7 days a week or not accept the patient. So basically 5 days a week is the minimum, but the frequency of rehab has to be based on an assessment of the patient and the plan of care. So there are several categories of skilled care, including management and evaluation of the plan of care, observation and assessment, teaching and training, skill therapy, and then potentially other considerations, so services provided as a practical matter or the availability of alternative facilities. So there are many, many, many examples of skilled care in the Medicare Benefits Manual, Chapter 8, and I strongly encourage you to look at that. Now, I want to make one other comment here, and that is frequently when we are looking to admit a patient to swing bed, we automatically think about skill therapy or wound care or IV antibiotics. So yes, those are definitely important and criteria, but there are also other types of skilled care that can qualify a patient. So including that evaluation of the plan of care. So medication management, if the physician is trying to regulate, for example, a medication regimen, teaching and training to teach a patient to care for a colostomy or whatever that might be. So when you're categories of skilled care, just expand your horizons just a bit to think about some of these other categories that Medicare allows to be admitted to swing bed. And check out the Medicare Benefits Chapter 8. All right. So let's start with pre-admission. So the first question, and probably the most important, is can you meet the needs of the patient? So as I said earlier, for example, if therapy is needed 7 days a week, but you can't provide therapy 7 days a week, then obviously you shouldn't admit the patient. Or if a patient needs speech therapy and you don't provide that, then obviously you would not admit a patient who needs speech therapy. So I highly recommend that you develop facility-specific admission criteria. Now, this is just an example. Yours could look very different. But if you develop admission criteria, it helps in a couple of ways. So one, it makes sure that the team is in concurrence, including the providers. And two, it can decrease the time from referral to admission. So if you don't have admission criteria, I would strongly recommend that you develop that. It's also important not to be surprised. So I don't know if any of you have accepted a patient from a referral facility, and once the patient arrives, they are very, very different than what you were told. So I have included in the appendix an example of a pre-admission checklist. It behooves you to really understand what the needs are of the patient before you accept that patient. All right, let's move on to admission. So I often get questions about the clinical record. So Medicare actually allows you to use the same clinical record if the patient was an inpatient prior to being admitted to swing bed. However, if you do that, the two components of the record have to stand alone. In other words, they have to be separated. And honestly, because of that, most facilities will opt for a new medical record with a new medical record number. But if you keep a single medical record, it has to stand alone. Physician certification. So CMS requires that for a patient to be admitted to swing bed, there must be physician certification, and then there's also requirements for recertification. There is no form that is prescribed by Medicare. So sometimes physicians will put this in progress notes, sometimes in an H&P. Some facilities have a stamp, or they do an EMR form that they ask the physician to fill out. If you have physician assistants, they cannot sign a certification or recertification statement if they are employed by the facility. Now, if they are employed by the physician, then yes, they can sign it, but otherwise, no. All right. So what does the certification look like? So one, it must clearly indicate that the services were required to be given on an inpatient basis because of the individual's need for daily skilled care for an ongoing condition, which was part of either a hospital admission or a SNF, or a new condition. We talked about that a little bit. So certification must be obtained at the time of admission or as soon as possible thereafter. So waiting 3, 4, 5 days is really not permissible. That initial physician certification needs to be done at the time of admission. The recertification is done at 14 days and then every 30 days thereafter. So remember, depending upon your length of stay in swing bed, patients may need a recertification in addition to that initial certification. So this is just an example. It certainly is not something magical, but it includes all of the requirements from CMS relative to both certification and, frankly, recertification. So if you don't have some sort of form in place, that needs to be part of your admission process. All right. So when you admit a patient to swing bed, the CMS requires that there are certain disclosures that you have to provide to the patient. So patient rights and responsibilities, how to file a complaint, a grievance, visitation rights, advance directive, choice of physicians, financial obligations, transfer and discharge, notice of privacy practices, and information regarding abuse and neglect, and then contact information for hospital and state agencies, including the ombudsman. So we're going to talk about a few of those individually, but when you are looking at your patient admission disclosures, you need to make sure that they include all of these items. So this is just an example of a signature page that you could give to your patients to sign. The only thing I would say is that make sure that this, if you do have a form like this, that it's included in the medical record. And also that you make sure that you, in fact, have all of this information that you're providing to the patient. So, all right. So let's talk about each one of those just a little bit. So the first is patient rights. So Medicare requires that the hospital is in substantial compliance with the patient rights. And I need to back up here just a minute. For the slides, I am using the critical access regs. I didn't include all of the regs in Appendix A. However, they are all basically identical except for the patient assessment, and we'll talk about that when we get here. Anyway, so the cause of substantial compliance with residents' rights, and Appendix PP, that's the F tags, require that that be provided both orally and in writing. So you also have to provide the patient with a copy at a minimum of the patient rights, and ideally the whole admission packet. And then I've also provided for you the CIHQ references to patient rights. So in the appendix, I have given you an example of patient rights, but a couple of important things. So one, they are not the same as hospital patient rights, and they are not the same as SNF long-term care rights. The swing bed rights are similar but different. You must also you must also disclose financial obligations, both for Medicaid eligible or Medicaid patients and Medicare. So for Medicaid, you must disclose items and services that are included, and then those items and services that you provide, but which the patient can be charged for. You must also then give the patient information when that changes. Let me go back one. Sorry about that. I guess I didn't put in the Medicare slide. So for Medicare patients, you are also required to provide financial obligations, including copay. So ensure, I believe the copay at day 21 is $204 in 2024. So the financial obligations need to include both Medicaid and Medicare. So there is, well, and there it is. See, I just needed to go one more slide. Sorry. As you know, there's no length of stay restrictions for swing bed as long as the patient meets skill criteria. However, for Medicare, copay is required from day 21 through 100, and then after day 100, all costs. So this is important to provide to your patients, but you also need to make sure that you update this every year. So when I do swing bed audits, frequently I will find information where the copay is 2 or 3 years back. So it gets updated every January. Make sure that you update your information that you provide to patients as well. Choice of physicians. This is always controversial. I get it. But patients do have a right to choose an attending physician. The caveats are that the physician has to be licensed to practice in your facility. Also, if the physician chosen by the resident refuses, then you are obligated to go back to the patient, let them know, and see if they want to choose another physician. So this is just an example of disclosure, because I know many of you have hospitalist groups, or you may only have a few physicians that take care of swing bed patients. So you can certainly disclose that you have a hospitalist group and allow the patient to choose that group, but you also have to allow them to choose a different physician if they would like Dr. Jones, who has cared for their family for 20 years. They can also choose Dr. Jones as long as he's on your medical staff. And in addition to providing choice, then you also must ensure that each patient is informed of the name, specialty, and a way of contacting that physician responsible for their care. So the comprehensive assessment. So this is where Appendix W and Appendix A diverge. So those hospitals who have a swing bed program, your comprehensive assessment is really done through the MDS and submitted to CMS. For critical access hospitals, you do not have to complete an MDS, but you do have to complete a comprehensive assessment that is very, very similar to what is required in the MDS. And I've listed all of the components of that assessment for you. So the time frames for the assessment must be appropriate for the length of stay in your facility. So for example, if your average length of stay is 12 days, then the assessment should be completed within 24 to 40 hours. So some organizations allow 72 to span a weekend. The assessment should be multidisciplinary, not just nursing, and that assessment forms the basis for your multidisciplinary plan of care. One of the requirements that that must be assessed is trauma-informed care. Now, the reg basically says that you're required to provide culturally competent and trauma-informed care. The goal is not therapy, but rather to eliminate or mitigate triggers that could cause re-traumatization for the resident. Here are some questions. They're mine. You may have your own, or your social worker may have some, but they're just really, really simple questions to determine whether or not your patient has had any trauma in their life, and if there is anything you need to do while they're hospitalized to mitigate that. CIHQ requires that you provide activities, and the reference is here. Appendix W only requires that you assess activity pursuit. The requirement for a formal activities program went away with the last update to Appendix W. However, Appendix A, so hospitals, still must have a formal activities program that's overseen by a qualified professional, either a therapeutic recreational specialist, an activities professional, or an occupational therapist. So there is some difference here in the CMS requirements for hospitals and critical access hospitals, although CIHQ requires a formal program. All right, so this is just from Appendix PP, and it really talks about the intent of activities. And the reason I bring that up is because even though Appendix W no longer requires a formal activities program, it's not appropriate for a 10, 12, 14 or day or longer stay to not have some way to ensure the patient's psychosocial well-being. So even if it is not required, I strongly recommend that you implement an activities program in your swing bed if you're a critical access hospital. So this is a ceiling, can you tell? So this is not activities, looking at the ceiling. So I do have some examples that I'd be glad to send you if you would like. This may be a little hard to read, but this is just an example of an activities assessment plan and documentation that were provided by Adventist Health Howard Memorial. But bottom line, whether or not you are a CAW or a hospital, activities are extremely important to your patients and to make sure that they have ways to stay engaged and ensure that their psychosocial well-being is being managed. Another requirement is the PASAR. So you are not required to complete a PASAR unless it's required in your state, but you are required to, if the patient has had a PASAR, for example, they come from a long-term care facility, then you are obligated to review the PASAR and incorporate the findings into your plan of care or document why not. All right, so this is just a little bit more about the PASAR. Basically what I was saying, if you disagree with the findings, then you must document. If you don't, then you must include the findings in your plan of care. All right. So the multidisciplinary plan of care starts with the comprehensive assessment. If you don't have a comprehensive assessment, then it's very difficult to develop a multidisciplinary plan of care. So there are some barriers, unfortunately, at least for critical access hospitals. The regulations were written for long-term care and skilled nursing, although they do apply. And of course, we know that the MDS process guides the plan of care in those facilities as well as hospitals. Nursing staff are not always educated about how to write goals that are measurable and time limited. although we frequently have informal conversations, we don't always have formal meetings with the intent of developing a comprehensive care plan. Documentation templates and EMRs are not necessarily set up for multidisciplinary documentation. It takes time, especially with a short length of stay, and then scheduling meetings at a time that everyone on the team can attend. So I'm hoping that your facility has overcome all of those barriers. Okay, so basically the regs say that you must develop a multidisciplinary plan of care with measurable objectives and timeframes, and that is really key, measurable objectives and timeframes. To attain, maintain the resident's highest practical, physical, mental, and psychosocial well-being, excluding when the patient exercises their rights, and then any specialized services as a result of the PASAR. So the multidisciplinary plan of care has to include all of those elements. The patient has the right to participate in the development and implementation. The comprehensive care plan has to include the resident's goals for admission and outcomes and their preference and potential for future discharge. Now, sometimes that gets documented in a case management note, and that's okay, as long as it's taken into consideration as part of developing the plan of care. In addition, the plan of care has to be prepared by an interdisciplinary team, and that includes the attending physician, the RN with responsibility for the patient, a nurse aide with responsibility for the patient, a member of food and nutrition services, to the extent practical, the patient, and then other disciplines as appropriate or as needed based on the resident's needs. But that core group is key. So sometimes when I do swing bed audits, what I find is that one or more of those individuals do not attend the interdisciplinary meeting, or they are not involved in developing the multidisciplinary plan of care. So physician, RN, nurse's aide, food and nutrition, and the patient are all required. So other members certainly can include the case manager, pharmacy, cardiopulmonary, etc. So really it depends on the needs of the patient. It's important to know that each discipline documenting separately is not a multidisciplinary plan of care. The intent is to share ideas, plans, and to integrate assessments and recommendations. So this is an example of a multidisciplinary plan of care. Now, I recognize that most EMRs do not support this type of a template, but think about it in relationship to how you can utilize your EMR to make sure that you're documenting long-term goals, short-term goals, interventions that are measurable and time limited, and responsible discipline. It's also important to post the plan of care in the patient's room and or give them a copy to sign. So this is in Appendix PP, but it includes the patient's right to see the plan, including the right to sign. I have seen surveyors cite hospitals for not doing this. All right, continued stay. So one of the things that I find that gets frequently missed in continued stay is a reassessment after significant change. Now, I believe absolutely that the patient is getting reassessed after a change, but it doesn't always get documented in the medical record relative to what the change has been, and then reassessment or of the patient care plan. In other words, an update of the patient care plan. So all of these things that are listed are defined as a significant change. So deterioration in activities of daily living, loss of ability to ambulate or use hands, deterioration in behavior, and in a resident's health status. So we usually get that health status one, but I'm not sure that we always recognize the others. Patients have the right to be free from abuse, neglect, and exploitation. So there are multiple regs around freedom from abuse, neglect, or exploitation. It actually includes also misappropriation of property. So you must have a policy and you must educate staff about abuse. This is not the same as abuse for a patient that may come into the emergency room who's been physically abused or sexually assaulted. This is more about internal to your facility. All right. There must be a background check prior to the first day of work for all staff, regardless of department, including registry and contract, because the reg says that you cannot employ or engage individuals who have been found guilty of abuse, neglect, exploitation, misappropriation of property, or mistreatment by a court of law. So you must do a background check. When you look at the regs related to abuse, there are very specific timelines for reporting once abuse is identified. They are exactly the same as in Appendix PP for long-term care. Nutrition. Nutrition is extremely important since most of your swing bed patients are older. You must provide dietary services to meet clinical and nutritional needs. Now, oftentimes what I see is that a dietitian is only consulted if the nurses screen the patient to be at nutritional risk. It is important for 100% of your swing bed patients to have a dietitian assessment. A nursing screen is not the same as an assessment by a qualified professional. Dental services. So the requirement went away to have a dentist on contract with the facility, but you must still have a policy and provide referral to a dentist when needed. So specifically, you must assist the patient with making appointments, arrange transportation, and if it is a result of lost or damaged dentures, then you must make that referral within 3 days. Medication management, there's no specific requirements. All of the requirements in Appendix W, Appendix A, CIHQ apply. I wanted to point out a couple of things though. Even though you are not required to meet this reg about psychotropic and unnecessary drugs, if any of you have swing bed patients that stay for an extended length of time, I know in some states they have what they call long-term care swing, then I would strongly recommend that you implement those standards in Appendix PP for psychotropic and unnecessary drugs, including pharmacist review and gradual dose reduction. All right, so we're almost there. Discharge. So discharge rights include the patient's right to remain in the facility unless one of multiple things occurs. Now, for swing bed, usually what happens is B. So the transfer or discharge is appropriate because health has improved sufficiently. So rarely do these other things happen, but occasionally, like the safety of the facility, individuals are endangered, etc. But usually we are going to transfer or discharge patients because basically the patient's better and ready to go to the next post-acute care provider or home. When you discharge a patient to a post-acute provider, so for example, a SNF, you must provide the patient with both quality and resource use data. This also includes, by the way, if you have a patient in the inpatient status who you are moving or transferring to swing bed, this also applies. So anytime the patient moves from inpatient to swing, then you must provide them with information about providers, including quality measures and data on resource use. So at time of discharge, but also when you move from inpatient to swing. So unfortunately, there's no comparable publicly available data for swing bed. So you can provide patients with internally collected data. You can provide them information from Hospital Compare, even though it doesn't really include swing bed, or just disclose that there's no publicly available data. So this is what Nursing Home Compare looks like. So if you're transferring to long-term care or a skilled nursing facility, so it does provide you with information about health inspections, staffing, quality measures, and then overall. So that's the type of information that you need to provide to the patient and give them a choice. So just a few other discharge requirements. So when you discharge a patient, the receiving provider must include some minimum information, and that includes contact information of the physician, resident representative information, advanced directives, special instructions for ongoing care, comprehensive care plan goals. So remember, we did care plan goals when the patient was admitted. Then at discharge, those need to be updated and then provided to the next post-acute care provider. And then a discharge summary. All right. So in addition to that, a recapitulation of the resident's stay. So usually that's part of the discharge summary, and then a final summary of the patient's status. So the regs actually say that you go back and complete the comprehensive assessment again, and then basically look at it, or I should say, do another assessment to provide information about the patient's discharge status. I will tell you honestly, I don't see facilities doing that very often, even though it is in the regs, but at a minimum, you should be providing and updating the plan of care and including the status at the time of discharge. All right, so reconciliation of discharge medications and then a post-discharge plan of care. All right, you must also, there are two notices that you have to give the patient. So one is a discharge notice. There is no CMS form for the discharge notice, but you'll have to develop your own form. But you must give that patient the discharge notice. It's not specific about how soon or how long prior to discharge that you must give that, but I would recommend as soon as possible when you have a discharge date. And this is just an example of a discharge form. And again, there is no CMS form. Oh, and here's the timing, sorry. So the regs say that you must give the discharge notice to the patient at least 30 days before the patient is discharged, or as we said before, if the patient has improved sufficiently so the resident no longer needs the services, then you're going to provide that notice as soon as you have a discharge date. You must also give the patient a notice of Medicare non-coverage. So you're really giving them two notices. So a notice of discharge and a notice of Medicare non-coverage. That has to be provided 2 days before the covered services end. And as I'm sure you know, patients have a right to appeal, and you cannot transfer or discharge them while that appeal is pending. Right. You must also notify the ombudsman of the discharge. Now, I know, absolutely know, that often the ombudsman will tell you, don't send it to me, I don't want it, I have nothing to do with swing beds. And so your information, what to the ombudsman is, well, okay, as soon as CMS changes the regs, I'll stop sending it. But basically, you are required to send the notice of discharge to the ombudsman. So that's it. I actually think we have a few minutes for questions. So, Michelle, let me see if I can pull these over.
Okay, yes, Miss Carolyn. Miss Carolyn, will you mute while I ask the question? I think that might get rid of the echo for us.
Okay, I'm sorry, what?
Will you mute while I ask questions, and that might get rid of the echo that folks are hearing? We'll give that a try.
Okay, all right,
So,
whatever
okay.
works.
Okay, so as a reminder, type any questions into the question pane. The PowerPoint is available in the handout section, and if you can't see it, please refresh your screen to capture the update. I'll leave the webinar live until most of you have dropped off so that you have plenty of time to access them. Let's see, your first question, is a social worker required for swing bed residents?
No. So a social worker is not required. However, the regs say that you must provide, and I apologize in advance if I get it exactly, if I don't get it exactly right, but you must provide, says something about you must provide social services if needed by the patient, but it does not require a licensed social worker. Usually case management, discharge planning will fill that role. If you have a need that really requires a licensed social worker, let's say, I don't know, then yes, you would have to provide that. But no, basically you do not have to have a social worker.
Thank you, Carolyn. Here's another. How do you handle documenting all the required patient rights for patients who are unable due to competency and may not have a relative available?
Well, that's a tough one.
Thank you, Margaret.
So I guess I would make every attempt I could to be able to find a relative or an individual who's responsible for the patient. And I suppose if you really don't have anyone and the patient is not competent, then you might have to go down the road of requesting a guardianship or conservatorship. But I would just, if you really truly can't get a hold of anyone, just document your attempts and that you were not able to get a hold of anyone.
Okay, another question. We're having a hard time with the care plan. We are finding examples, but they vary greatly. Is there a care plan template that you would recommend? That's from Andrew Chapin.
So I heard, sorry, Michelle. So I didn't hear the first part. Could you do it again, please?
Miss Carolyn, I'm sorry, I deleted the question. Let's see, here's another one. And if you just submitted the recent one, will you please resubmit? Here's a new question. We have PCTs and not all of them are CNAs. Is it required that they have a CNA?
Is it, so I think, so Michelle, I think what you said was, is it required that you have a CNA? Is that correct?
Yes, ma'am, that's correct.
Okay, sorry. So no, you do not have to have CNAs, but if you do have them, then they need to be a participant in that multidisciplinary plan of care and developing that plan of care.
Okay, let's see. Here it is. We are having a hard time with the care plan. The example we have vary greatly. Do you have a care plan template? That was from Andrew. I think you answered that one. Oh, a care plan template. That was the question from Andrew. Do you have a care plan? Yes.
So the question was about the care plan template?
Yes. Do you have one that you can recommend?
Oh, Lord. Sorry, shouldn't have said that on a live webinar, should I? I have, so I'm trying to think. So I've seen, other than the one I showed you, I have seen hospitals will I've seen them build, I think it's called a dot phrase. I've had one hospital do that. Others will simply have the case manager or discharge planner, whoever is participating in the or running the multidisciplinary conference, will do a summary of the goals, and then indicate, refer back to PT note, OT note, dietary note, etc. The problem is, if you do it that way, you still have to be clear about what the goal is and whether it's being met or not met. But it does reduce the amount of documentation in the multidisciplinary plan of care. I have a couple of hospitals that use hard copy because they've kind of given up figuring out how to do it on the EMR. I don't know if that's the best solution either. So maybe not good choices, because I know it's hard. So sorry, that's the best I can do.
Okay, a follow-on question to that one. I'm going to jump a little bit. After developing the multidisciplinary plan of care, do you have suggestions for how to document the progress toward the goals? For example, how best can all the disciplines document in the same place? So this is similar to the previous question about the care plan template.
Right. So some, in fact, I was at a hospital recently, and they actually had a great multidisciplinary plan of care, and I can't remember what their EMR was. I'm thinking it's Epic, but I may be wrong about that. But all disciplines documented on the same plan of care, so they were not separate. At a minimum, again, I would document met, not met, or progressing as part of your multidisciplinary plan documentation of your meetings. So even if it's something simple, such as 14 days of IV antibiotics progressing, or something like that. I know this one is tough. I mean, I get it. If you are a hospital, not a CAW, then you have that wonderful MDS that helps you develop the plan of care. It's not easy. I have other organizations, other hospitals, where basically the case manager kind of duplicates, if you will, what's been written by the other disciplines, so it's in one document. That's a lot of work as well. So I don't have a good answer for you. I'm sorry. I wish I did. And let's all petition the EMR companies to build us a good template. So go. Next, Michelle.
Okay. Does critical access have different rules than a PPS hospital? This is from Belinda Ritchie.
Yes, they do. But it depends. So the basic requirements for a CAW and PPS hospital swing bed are the same. Where they diverge, where they're different, is that the PPS hospital completes the multidisciplinary assessment as part of their MDS, which then also helps to generate the plan of care. So if you put the critical access hospitals and the PPS hospital standards side by side, then the hospital standards are going to be silent where it comes to the multidisciplinary assessment and the multidisciplinary plan of care. The other place they differ, as we talked about, was that activities is not specifically required in a CAW. They are required, or it is required, in a PPS hospital, and it has to be a formal activities program. But other than that, the two regs, if you line them up, are going to be almost identical.
This from Jenny LaBelle. Are there any specific requirements around fall risk assessments or suggestions on what assessment should be utilized? We want to prevent falls, but also not be so restrictive in fall precautions that we are restricting the return to baseline.
Sorry, Michelle, I am so sorry, but I'm having trouble hearing you.
Okay.
So try that again. I
Sure.
can't see the question, so
Okay.
sorry. Could
Okay.
you try that one more time?
Yes, ma'am. Are there any specific requirements around fall risk assessments or a suggestion on what assessment should be utilized? They want to prevent
So,
falls, but also
so that
don't want to be restrictive in fall precautions that they restrict return to baseline.
okay, so that question was about fall risk, correct?
Yes, ma'am. And the assessment.
Fall risk. Okay. So so here's the dilemma, isn't it? So it, particularly in a swing bed, you want the patients to be independent so that they are increasing their functional status, so they're getting better. But then the the flip side of that is fall risk. So I think you have to use the same assessment that you would in a for your acute care patients. I don't think it should necessarily be different, but here's where you really need to make use of your physical therapist to help you develop an appropriate plan for how you encourage independence and minimize the risk of a fall. So utilize your PT professional. I think that's your best bet for preventing fall risk in your swing bed patients. Okay.
Okay.
Next, Michelle.
I've got one more. Melissa Lynham. We have swing bed patients admitted for rehab, and the patient refuses to work with therapy. So they have discussed using a contract for the patient so they understand that they may be discharged from the program if they consistently refuse to work with therapy. This is physical, occupational, and speech. What are your thoughts on that, a contract?
So if you have a patient, so I guess there's two sides to this. So one, if you have a patient who is consistently sorry, consistently refusing to work with therapy, then I'm not sure that you have any alternatives other than to discharge the patient. Now, I would, however, make sure that you are looking at what's the cause? Why is the patient refusing? So is it because they're in pain? Are we not medicating them appropriately before therapy appointments? I mean, it's hard to know, but if a patient is refusing, then there's generally a reason. So I would first dwell into what's the reason for the patient refusing. And then if they simply continue to refuse after you looked at the causes and trying to mitigate those, then yes, you probably don't have an alternative but to discharge them. Now, for some patients, that might mean discharge to long-term care because home or home with Hope Health is not a safe option. Okay, Michelle.
Okay, so that's all of the questions. Keisha had good luck logging out of the presentation and logging back in. If you are missing the slides, I will stay on the line until everyone is gone. If you want to try this or send me an email directly, and I'm happy to send you the slides as well. That's my error, and I apologize, but I'll make sure that they're readily available. And we'll also upload this to our new YouTube channel. That was a wonderful presentation from Melissa Lynham. Thank you so much for the great info. Thanks, everyone. Have a great day.
Thanks, Michelle.